So again, Dr. Zhao, it's really a pleasure to be here. I totally agree that there is no single sector that will solve this problem. It's not a federal problem, state, local, county problem. It's going to require a whole of society approach that includes academia, nonprofits, faith-based organizations, commercial corporations, healthcare systems. So that's the reason I'm here, is because this is a problem set that we all need to work together on, and I'm absolutely committed to do that. Just a note about my position, I was confirmed as the ASH on February 9th and started on the 15th. And that really is a public health position, the principal public health and science advisor to the secretary, whose mission in this office is, I believe, to transform the American healthcare system from a sick care system to a health promoting system. Later in March, the secretary asked me to take on the senior advisor role. This is a new sort of structural concept for the secretary. He has 4 major priorities: value-based health transformation, affordable and accessible access, reducing drug costs, and solving the opioid epidemic, and has put a single individual sort of as the point person for each of those. I don't take the place of SAMHSA or CMS or NIH or HRSA or anyone else, but my job is to make sure that this $1.5 trillion agency is working together seamlessly, that we're having initiatives that synergize with each other, because just as we require multi-sector efforts, there's almost no problem we face that doesn't require a whole of HHS effort. On a different level, this really is a whole of government effort. Many people I see here from the VA, other organizations, we see every week at the White House and the opioids cabinet. We also talk on the phone once a week with the opioids cabinet to make sure there's coordination. So this is a reach out, and the next logical step is to try to bring much more than government or state organizations together in a single collaborative. And I'm very appreciative of the National Academy, Dr. Perlin, everyone for making this possible. As the kickoff, I did want to start with some statistics and some baseline foundational information. I think most of us know, but this is being broadcast widely to make sure we're all on the same page. And then talk a little bit about HHS's approach, and then some of the things we're working on that we're in the formative phases of that may or may not become a topic of this. I think we all know this, and thanks to the CDC and Deb Howery here for their collection of data. Now, remember, we're 6 months behind in mortality, because it takes a minimum of 6 months to get reasonable numbers, and even those are not complete numbers for another few months. But based on the best estimates of the CDC, taking into account the confirmed deaths from substance overdoses and those that are predicted to be substance overdoses when they're finally resolved, we had over 72,000 deaths between December 2016 and 2017. Really, truly an astounding amount, with the opioid deaths being 49,000. And as several people have already said, although there's some positive trends, we are still increasing almost 10% year over year. We have not demonstrated as a government, as a society, that we can solve this symptom of an underlying problem that we have that is throughout all our segments of society. Opioid doses increased 11.7% year to year. And an absolutely shocking statistic to me, buried in a report that really showed that our young people are making much better choices about overall health choices. 1 in 7 US high school students report misusing opioids at some time. That is a real frightening statistic, which means we may be only seeing the first wave of this hitting, and there may be another wave coming down the pike. I think all of you know the general statistics about where the deaths are. This is about a year old, but it still tracks this way. For opioids, we are really in a crisis of synthetic opioids, of fentanyl and carfentanil, much more than heroin, methadone, anything else. These are highly potent agents. They're very cheap to manufacture. They're being transmitted to the United States, primarily in the international mail system, in quantities that are truly unbelievable. And I'll talk about that in a second. Someone brought the statistic up, and I just thought I'd put a chart together because, you know, I'm a doc, I'm a scientist, I'm in the government, so why not make a PowerPoint chart? But I think it really does show, if you look at all the combat deaths in World War I, II, Korea, and Vietnam, even just in the last 18 years, the number of opioid deaths almost equals that, and the number of overdose deaths far surpasses all our combat deaths in our major conflicts in this century. Quite an alarming statistic, and by the end of this year, I'm sure opioids will surpass that together. Data published in JAMA really point out some of the issues, I think, graphically, incredibly importantly. I do have a pointer. I do have a pointer here. So if you look at these charts, this looks at the increasing percentage over time from 2001, 6, 11, and 16 of the percent of deaths within that age cohort. And between 25 and 34 years old, 20% of all deaths in that cohort are due to opioids. Really an astounding statistic. Somewhere between 2.5 and 3% of all mortality in the U.S. is now due to overdose deaths, and in some states that's over 5%. Again, adapted from the CDC statistics, and this is a couple months old, but the trends are still there. If you look at the increases year to year, heroin is kind of flat. Natural and semi-synthetic opioids, meaning the prescription drugs themselves, are kind of flat. Methadone is down. Synthetic opioids up 57% in terms of death. But let's not forget other aspects that are rearing their head again. Cocaine use is up dramatically. Cocaine importation in the U.S. is up by tens of tons per year. Psychostimulants, mainly meth, again up 35% year over year. And as all of us know, we are in a really bad situation because now basically every drug is contaminated with fentanyl. The CDC director, Dr. Bob Redfield, recounted publicly last week how his son almost died. He was using cocaine that was laced with fentanyl and overdosed and almost died himself. As you know, the Surgeon General's brother, I think the most dramatic illustration of how it can happen to anybody. His brother is now incarcerated and has been in and out of substance abuse program and has been addicted for most of his adult life. One brother in and out of the criminal justice system with substance use disorder, the other brother, the Surgeon General. It can happen to that family. It can certainly happen to anyone. To give you an idea of this, it shocks me because as an intensivist, pediatric intensivist, only intensivists or anesthesiologists were able to use fentanyl in my hospital because of how powerful it was. Here, there was a drug bust, not due to signals intelligence or anything fancy, but just some good policing of a suspicious truck on the side of the road in Nebraska. And it just happened to have 118 pounds of fentanyl in that truck. That's easily enough fentanyl to kill 26 million people in the United States. So the magnitude of the problem of illegal, illicit fentanyl, and now even carfentanil, which is 100 times more potent than fentanyl, is really defining the problem in the United States right now. And as was said earlier, I think by Dr. Perlin, and this may be changing a little bit as the crisis evolves, about 70% of people who use heroin or fentanyl now started out with prescription opioids. It may have been their prescription, or it may have been a prescription that was used by someone in the family and left in the medicine cabinet and was used sort of off-label and inappropriately. But that may shift a little bit, but the problem really is now prescriptions over to illicit drugs because they're cheaper and more available, and that brings up one of the trade-offs. Certainly we have to decrease the amount of prescription opioids, but if we crash that right now, we're going to shift people, if they don't have treatment for their substance use disorder, they're going to shift to the street drugs and be at high likelihood of dying. You can pick a number, whatever the number, it's a lot. The Council of Economic Advisors says that the cost in 2015 was $504 billion. The CDC tends to use a number that would equate more to $130 or $150 billion because they don't really look at the overall cost of a statistical life. Any way you count it, this is a huge economic crisis as well as a health crisis and a tragedy for Americans all around. I'm very pleased that the National Academies, the first thing I did, I think the first talk I gave was at our OASH workshop where the National Academies helped us to try to attack the comorbid situations, HIV, hepatitis B, hepatitis C, increasing endocarditis, skin, bone infections, often with resistant organisms that are the syndemic consequences of the opioid epidemic with injection drug use. So we don't want to forget about these other epidemics that are occurring in conjunction with and as a result of injection drug use. Again, dramatically underreported. The CDC estimates this may be tenfold underreported, but based on the reporting, hepatitis C infections are up 233% between 2010 and 2016. And this truly is the tip of the iceberg. So while we're working on our issues, we also have to worry about the infectious disease consequences. And again, I'm very thankful to the National Academy for providing us some opportunities that we had not otherwise anticipated to attack this problem. As a pediatrician, I am very concerned about neonatal abstinence syndrome. These are the charts. There are about 25,000, again, probably grossly underestimated. of children born with NAS in the United States. We think about a jittery baby who may have seizures, but that's one aspect of it. I'm more concerned because that may be important, but when you have premature birth, a 25-weeker, because of the mom having in and out of heroin and fentanyl, the consequences of a 25-weeker are probably even more important than the neonatal abstinence syndrome in a term baby. And we are very interested in and a bit frightened by some preliminary data that these children may have very long-term developmental disorders requiring special education and other interventions. So we may be only seeing the first wave, and the hidden epidemic may be coming with our children. We are very interested in setting up systems to follow these and other children so they can have appropriate intervention on the human services side, the HHS side, and coordinate that activity. And I'll have a little bit more to say about that. I was just at Vanderbilt a couple of days ago. The First Lady joined me during that trip. She is exceedingly interested in child outcomes of substance abuse mothers. So we have the First Lady, the power of the First Lady's office to help champion this cause. Oops, wrong slide. I was in Tennessee. I didn't mean to have that in there. But we can talk about Tennessee if you'd like. I think all of you know that there's a 5-point strategy. And at this level, I would like to overview that. We have over 700 individual initiatives that relate to this 5-point strategy. We'll be rolling out a much more specific strategy within this strategy later on in September. But in general, our approach is the following. And again, I'd be very happy to answer questions either after this or sometime during the day. Is the first to strengthen public health data reporting and collection. We want to be evidence-based, but in order to be evidence-based, you got to have the data and you got to have the evidence. And the CDC is a primary warrior in this regard, but it's really a coordination between the CDC and state and local authorities. You can't report if you don't have the medical examiner, coroner systems, if you don't have the diagnostics, if you don't have the electronic reporting. So this is really, really a heavy lift. And the CDC has done a tremendous job with the local authorities to improve reporting. So at least at 6 months, we have a good idea. I've certainly challenged them to get that down to 3 or 4 months so we can have much more granular data. But across the board, whether it's the NISDA database that comes out of SAMHSA, whether it's the multiple CDC databases, whether it's the ESUS database, which is the overdose database that allows counties to get within 24 to 48 hours what's going on locally within the county and state, so it could be very actionable. We need to really be in a data-rich environment. We have many, many needs, but we're moving in that direction. And certainly the President and Congress has supported quite generously funding. Secondly, advance the practice of pain management to decrease the inappropriate use of opioids. I think we all know that. The CDC had the first shot across the bow with their guidelines in 2016, but there's been enormous activity since then at CMS, more at CDC, certainly from my office, the Surgeon General's office. There is the Interagency Pain Task Force being chaired by my office right now, but with DOD and VA at the table. And I do want to emphasize we are highly cognizant of the fact that we want to decrease inappropriate use of opioids, not appropriate use of opioids, until we can get non-addictive, more effective alternative pain medications through that. Improve access to prevention, treatment, and recovery services. I think Dr. McCann's Katz will be here later on, but she has certainly been the champion of absolutely putting forward that this, and we all believe and agree that addiction is a disease. It changes the brain. It must be accompanied by treatment, and that treatment is not one thing alone. It's medication-assisted treatment with psychosocial support, but also with the wraparound services for recovery that are so critical. Those are 3 legs, and you can't lose one of them. And we'll talk about that, but certainly through her grants, if you don't provide MAT or offer it seriously, you are not eligible for federal funding. Enhance the availability of overdose reversing medications. Naloxone does not solve the problem, but it gives a person a second chance at life. So we are very bullish on providing naloxone as much as possible, lowering the barriers to having it done. There are standing orders in all 50 states, and I'll talk about that now. And again, this is one of the Surgeon General's primary causes. And finally, research on pain and addiction. I think this has been this has been a crisis looming for a long period of time, and I think we have not invested enough into the research enterprise to change really the paradigms of how we treat pain, to provide holistic services, public health interventions, not just on the a new whiz bag drug to treat addiction, but how do we deliver those services? How do we provide a system of care that provides long-term recovery for individuals? Again, we can go into all of this. I thought this was, I just wanted to put this up here because it was sort of a relearning experience for me. I'd been at DARPA for 4.5 years, which is a very small part of the federal government. But the HHS approach, just for everyone to think about here, because many people in academia really look at the government as a grant source, which it is. There's $37 billion at the NIH. There's multiple, oh, there's Dr. McCann's cats back there. Hi. There are obviously billions of dollars of states awards going through SAMHSA, but there's lots of things that we can pull on. The first one is reimbursement. The Congress may allocate and the president may request $5-6 billion a year in extra opioid funding, but CMS's budget is $1.2 trillion. So if you really want to move the system and sustain it, we really have to have reimbursement the right way. We can train behavioral health providers, we can train peer recovery coaches, we can train everything we want, but if they're not reimbursed in a right way in a system without paperwork, it's not going to be sustainable. A few $1 billion is really a drop in the bucket compared to the needs of the healthcare system. So we are very concerned with reimbursement, which is one reason why CMS is always at our table working on how we provide holistic solutions. Regulations, very important. Regulations can help, they can also hurt. These are things that don't require legislation, but are very important. For example, clarification of DEA side that MAT can be provided by telemedicine as long as there's a DEA certified provider on the other side. That's very important. It changes the entire equation about who needs to be in rural areas and how it can be delivered, and opens tremendously. Grants and contracts, obviously, the NIH through their grant system, SAMHSA through their grants and contracts, HRSA through their grants and contracts. Not only does it provide funds, but it also provides direction. For example, the state targeted grants that really focuses on evidence-based therapy and the requirement for MAT to be reimbursed. So it really pushes things forward. Interdiction and enforcement. Even at HHS, the FDA has a large presence at international mail facilities to stop the trafficking of fentanyl and carfentanil. Policies and, of course, guidelines and technical assistance. Again, I'm much closer to SAMHSA on this, but HRSA, CMS, all has technical assistance programs and guidelines to help people understand how to best practice, and a phone home solution that if you need help, you can always get help on the other end of that situation. CDC, obviously, guidelines across the board, and we're working on that as well. Just to show you just a few bits of trends, U.S. opioid prescriptions, you can start wherever they are. I did not have the MME because I wanted the most recent data, and we don't have those calculated yet. But if you look at the number of prescriptions per month, it still astounds me that there are 20 million prescriptions per month for opioids. But between January 2015 and June of 2018, the number, just the raw number of U.S. prescriptions are down 24%. If you look at 2017 alone, MME is down about 13% in that year, the largest decline. So clearly, people are getting the message. Some health systems like the VA have been leaders in their organization. Some private healthcare systems are also leaders. This is very inconsistent across the country. We see pockets of excellence. We see pockets of people still doing prescribing practices from the mid-2000s. Buprenorphine and naltrexone prescriptions. These are outpatient prescriptions only for MAT. We don't have the, because it's a different database and sort of there's some fuzziness around that about methadone prescriptions from opioid treatment programs. But just looking at this snapshot, you can see that clearly we're getting the message. This is the number of prescriptions. You can also look at it as the number of patients. No matter how you calculate it, we're going in the right direction, but we are far, far, far away from giving treatment to the number of patients who need it. We're looking forward to the new NISDA numbers. The last NISDA numbers, I think, said about only 20% of people who should be on MAT have MAT. I'm curious to see where that bar has gone, and we should have that out pretty soon. But no matter how you cut it, if you look at these data, there's a lot of room for improvement. Naloxone doing pretty well. Naloxone's getting out there. This is the prescriptions, but if you look at actual distribution that are not prescriptions, it's very similar. Naloxone is going up tremendously. We don't have a good metric about how much naloxone is enough. How do you measure that per the number of overdoses, per the number of opioid prescriptions, per MME? We don't really have a good metric to shoot for, but we know more is probably better. So that's going up pretty significantly. The president's budget calls for, and I have 2 slides left, so I'm 2 minutes late. The president's budget, which we are very confident will be supported by Congress, if not upped by Congress, has $150 million primarily for the infectious consequences, another $1 billion to SAMHSA for the state targeted grants, $150 million specifically for rural health, substance abuse, and OUD, $544 million for community health centers. We think they're a very, very important tool in the fight, and Dr. Segunas has ramped up his commitment to providing MAT and behavioral health services. Another $300 million for CDC surveillance, including infectious diseases, and $860 million for the NIH. I think that puts the NIH somewhere around 1.5 or 1.6 billion, Dr. Baker, that is in this area of pain or substance abuse work. And I think the NIH is being very innovative of not just doing just basic R01 grants, but truly innovative challenge grants to understand how we could deliver care. Last slide, a few things on my mind. Well, second to last slide. Some OUD related initiatives in development. So these are just some thoughts of things that we are working very, very hard on with the primaries, the principals involved. Integrating programs across the U.S. government. That means not just HHS, but across the U.S. government, housing and urban development, DOJ, including DEA within that, and other aspects to substantially impact SUD overdoses and deaths in a highly stricken community. How do we really integrate this in one big effort that we can really show that we can beat this outbreak and not have 10% increase year over year, but can substantially decrease it? How do we address the barriers to SUD treatment in rural communities? There's been a lot of work on that, but there's a lot of opportunity, particularly with USDA collaborating with HHS, particularly SAMHSA and HRSA. Third, assuring adequate pain management for special needs patient populations, including cancer, sickle cell disease, other debilitating conditions. Very high on my list. I've been an advocate for sickle cell for a long time, being a pediatric critical care physician, also have personal interests from children we have mentored over the years. So we are emphasizing always and hearing horror stories on the contrary, that people who at this time need those medications are not getting it. How do we expand the current CDC guidelines to include specific recommendations for certain conditions or medical procedures? So this is actually expanding, not that the current guidelines aren't sufficient, they're great, but how can we expand them and what is the evidence base? Should we and how can we enhance naloxone co-prescribing for select patient groups? The recommendation is over 50 MME, you should have a naloxone co-prescription. Well, sometimes the co-prescriptions are very expensive, so they might be prescribed and not filled. And in many circumstances, they're just not co-prescribed at all. And some very, very large data groups show that even with people over 120 MME, the rates of co-prescribing or co-filling is less than 2%. So we have a lot of work to go with that. Transforming the U.S. healthcare workforce to meet behavioral health needs across the spectrum. And of course, we're talking about opioids, but how about substance abuse in general? Alcohol, smoking are all the health behaviors that are the focus of my daytime job, like fitness, obesity, diabetes care, nutrition, all the kind of things that are really behavior related. Have we trained the workforce to really deal with the crises of our times and for the next 20 years? And I'd say finally, optimizing and standardizing diagnosis and treatment of NAS, including integrated models of care and long-term follow-up, including payment. Although there's pockets of excellence, we still don't have real standardized definitions, diagnostics, clinical care scenarios for NAS, and very importantly, how do we follow all those children? This is only the tip of the iceberg, but I wanted to give you some thoughts about some of the main things that we're thinking of that we really think are the next level of sophistication in the outcome of the epidemic. This is not my area of practice, but I will tell you that I've been enormously touched and moved by what success looks like. Stetson in my arms there, unfortunately, the Surgeon General at Parkland, and we basically kidnapped this child away from his mother. He is a child, an NAS baby, whose mother is in long-term recovery and is doing great, has a job, supporting her family, and he is thriving as an individual. And I think if there's a vision of what success looks like, it's that. On the right, this is just the latest example of 3 women, 3 out of the 5 women there had horrible problems with substance use disorder and went through a year-long residential program in something called the Hoving Home in New York. They are thriving, doing well, raising their families. So whenever I sort of do gloom and doom, and there's a lot of gloom and doom, but there are a lot of things going in the right direction. And I always tell people, particularly given the advances in addiction medicine, in the treatment, in training, which many of you represent, that recovery is possible and it can be likely if people go into the right systems with the right supportive care. So that's all I wanted to say to kick this off. Again, I wanted to let you know that from my position within HHS, you have the secretary, the deputy secretary, all the principals' full support. This really is one of our top 4 priorities at the agency. It is a priority for the White House. You know, it's a priority for Congress. We don't have all the answers and want as much input as we can. And again, I thank you for the opportunity to participate in this. Thank you.